The quality of a CT image depends on the parameters we choose for acquiring the image, and chief among those are the KVP, the MAS, the slice thickness, how thick each individual slice is, and the gap between the slices, which can go everywhere from a well-defined gap to no gap to what some people call a negative gap, which is actually overlap of two slices. The trade-off is that you get better detail with thinner slices and less gap between the slices. Up to a point you get better detail with higher KVP and MAS, but all of those adjustments increase patient exposure, and that's undesirable. Years of experience have taught us what the optimal parameters are for each part of the body so that we don't have to reinvent the wheel each time a patient comes in for a CT of the chest or a CT of the brain. And we rely heavily on two things. One is the protocols that we have written to specify the scanning parameters, and the other essential component of the process is a good CT technologist who can take that protocol and adjust it as necessary so that a very fat patient may need a little extra KVP or MAS, or maybe even a slightly thicker slice, because there's so much more patient attenuating the X-ray beam. The software largely determines the smallest structures we can see, and as the software has improved, our ability to see smaller and smaller structures has improved. However, there is still a finite number below which we can't see. We don't do microscopy, but we can see sub-millimeter structures. Some of the smallest structures I routinely work with are the ossicles in the ear, the very small bones that are part of the hearing chain. And radiographs continue to have superb spatial resolution and occasionally can actually supplement or augment a CT.